Next slide, please. Changing. So this is the title of my talk, Changing Epidemiology of HBV in 2020. These are my disclosures. Next slide, please. Before talking on epidemiology, I just want to make a small introduction in terms of how we get HBV, how is it acquired. Next slide, please. As we know, HBV is transmitted by parental exposure, and for this, HBV is transmitted by blood and blood products, but also by body fluids such as urine, saliva, nasopharyngeal secretion, tears, vaginal secretion, menstrual blood, and semen. Not all of them have been shown that they transmit HBV, but most of them do, including saliva. And saliva's attachment to mucous membranes can also lead to transmission of HBV. Besides that, HBV can also survive outside the body for 7 days. So these are things which need to be considered in terms of transmission. Next slide, please. So in terms of epidemiology of HBV, we have to differentiate between vertical transmission, horizontal transmission, and transmission at adulthood. These three ways of paths of transmission also are linked to the high or low endemicity of HBV. I will come to that, but vertical transmission occurs perinatally and is associated with the highest rate of chronicity once it has gone to the offspring. It is associated with high rates of childhood. Is also associated with high rates of chronicity, and transmission at adulthood is seen mainly in hypoendemic areas of the world, and occurs either through sexual transmission, IV drug use, or contaminated needles, syringes, tattoos. Dental procedures can also be the cause. But most importantly, nowadays, it can occur. One risk factor is the immigrant population, and I will come to that. Next slide, please. So these are the most common routes of transmission. Vertical transmission, as I mentioned, it leads to more than 90% chronicity. And this is effective in endemic areas such as Asia and Sub-Saharan Africa. And the important thing to remember is that active passive immunoprophylaxis, so both the vaccine and hepatitis immunoglobulin, which appear to be the most effective ways of preventing vertical transmission, may not suffice to prevent vertical transmission in high viremic mothers. And for this, I will talk about that as well. Horizontal transmission is basically the way of the transmission route in intermediate endemic HBV, intermediately endemic countries. And when horizontal transmission occurs before the age of 5 years, it leads to around 30% chronicity in children. Next slide, please. So here we have it. Endemicity is high, intermediate, or low endemicity, and high endemic countries are mostly seen where countries where vertical transmission occurs. Intermediate in the endemicities are countries where mainly horizontal transmission in early childhood is taking place, and low endemic countries are countries where HBV is transmitted through in the context of high-risk behavior. And this high-risk behavior, however, includes not only sexual transmission, IV drug use, but nowadays the immigration population is important in that context. Next slide, please. Now, how can we prevent vertical transmission? Next, Can we continue? The maternal HBV DNA level is the only independent risk factor for mother-to-infant transmission. And if we look at the colors in the context of the numbers I've put here, is as you can see, if you have a viral load, or if the mother's HBV viral load is less than 6 logs in terms of copies per ml, vertical transmission is seen in none of the mothers to the infant. But if the viral load is 6 to 7 logs, 3.2% vertical transmission can take place. If the viral load is between 7 to 8%, 6.7%, and if the viral load is more than 8 logs, close to 8% of vertical transmission occurs. So the rate limiting factor is HBV DNA level, which suggests that, can you continue please? That if you have an HBV DNA level of less than 200,000 international units per ml, vertical transmission will not occur with the usual measures we take to prevent vertical transmission. But if it is above that, the usual measures which we have is HBV vaccination and hepatitis B immunoglobulin may not suffice to prevent vertical transmission, and we need to give these patients, next please, nucleoside analog in the 3rd trimester. If maternal DNA is very, very high, you may consider starting nucleoside analog even in the 2nd trimester. So, but the aim is to have an HBV DNA level of less than 200,000 international units per ml at the time of delivery. Next slide, please. And there is data to, can I have the next slide, please? Yes, there is data that indeed with nucleoside analog treatment in the 3rd trimester, you can prevent altogether vertical transmission. Now, in terms of vertical transmission, a landmark paper was published in 2007 by Brian McMahon's group, where he used a HBV cohort, which he followed for more than for a median duration of 20 years in Alaska. And there he was able to show that if in the latest serum sample, if the genotype was if the genotype was C, this was mostly associated with E antigen positivity. Next slide. Next, please. Next, please. And yes, can I have the next? Next. He was able to, they were able to show that, next, please. Yes, they were able to show that patients who had HBV genotype C, okay, can you go back? Can you go back? Can you go back? Patients who had HBV genotype C had E antigen seroconversion or E antigen clearance quite late. The 50% is 48 years of age for genotype C, whereas for the other genotypes for genotypes A, B, D, and F, it's less than 20 years of age. So basically, genotype C was associated with very late E antigen clearance, and that was one reason. Next slide, please. Why? This is genotype B and C. These are the colors for genotype B and C, as you can see, and this is the most common genotype in the Far East, and this is most likely the reason why you have a high rate of vertical transmission in countries like China and other countries. Now, in African countries, I'm sorry. This does not explain the situation in sub-Saharan Africa, but genotype E was not assessed in this study. Next slide, please. Next slide. Next. So global epidemiology of HBV, there are more than 2 billion people infected with HBV. They were encountered with HBV. So basically almost 1/4 of the world population has been encountered with HBV, but 250 or 270 million individuals are infected with chronic hepatitis B, and 15 to 25% die from cirrhosis or HCC. Age standard death rate is 6 per 100,000, and there are almost 700,000 deaths from HBV per year, almost 300,000 alone from HCC. The important thing about HBV is that its epidemiology is as expected, dynamic, it changes over time. Next slide, please. Next, yeah. So this is the study. This is a study from Schweitzer et al. Published in 2015 in Lancet. You may know this slide. What you can see is before 1990, China was a hyper-endemic country. India was a country of low intermediate endemicity in terms of HBV. Turkey was a country of high intermediate endemicity, and sub-Saharan African countries were mostly high endemic countries, or there was no data available. Now, next slide. Next slide. After 1990, can we go back? I'm sorry, can we go back? I'm sorry, After 1990, China has converted from high endemic to high intermediate endemicity. India has converted to low endemicity. In Turkey, for example, has converted to low intermediate endemicity. But sub-Saharan African countries continue to be high endemic. And we know what it means. High endemic is more than 8% of the prevalence of HBV in the community. Low intermediate endemicity is 2 to 8%. And low endemicity is less than 2%. So high endemic countries are, of course, a very important source for transmission. Low endemic countries, intermediate endemic countries are also very important in the context of transmission, in the context of immigration. And these are important on a global scale. Next slide, please. HBV epidemiology is dynamic because we have the effect of vaccination. Some of these numbers are thanks to very effective worldwide infant universal vaccination programs, which is now observed in more than 85% of the global countries. So it leads to decrease of HBV prevalence for future generations. But there are also other preventive strategies. With the HIV epidemic has led to precautions to be considered more intensely in the context of transmission. Migration, as I mentioned, and will continue to mention, is important. And antiviral therapies are also important. Next slide. The 21st century has witnessed a global migration event, and its effect is seen in many diseases. Next slide, please, including viral hepatitis. So as in low endemic countries, HBV is seen in adults, and it occurs in patients who have high risk in high risk individuals. And high risk behavior was limited to sexual transmission, heterosexual contact with multiple partners, men who have sex with men, and IV drug use is an important trigger for transmission. Okay, so my time is, and then we have contaminated needles and so on. But an important factor is immigration. Next slide, please. And it occurs from migrant countries of origin are mostly East Europe, Russia, Asian countries, African countries, where they have a prevalence of HBs antigen prevalence of 2 to 8%. To host countries where the prevalence is less than 1%, and it is seen in Northwest and Central Europe, North America, and Australia. So these are the host countries for migrants. And the difference is 10 times higher in migrant population. So definitely these are important risk factor for transmission of HBV. Next slide. I know my time is already almost up, so I will try to be quick. Can we go on, please? Next, 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 next. So I just want to mention here that the migration is a worldwide event in the 21st century. 3.5% of the world population is migrating. Now, if you compare, you can compare it to the IV drug user population, which makes up, the migrant population is 250 million, and the IV drug user population is 15 million. So it's 0.2%. This shows that IV drug use, although is an important factor for HBV transmission, is negligible if you compare that with migration. So today's problem is worldwide migration, and this is how HBV becomes an important problem also in areas of the world where HBV appear to be not a problem. Next slide, please. Next. And most of the migrants are from, as I said, 41% are from Asia, 20%, 25%, around 25% from Eastern Europe, and then comes Africa. And the host countries for migration, besides Saudi Arabia and United Arab Emirates, most of them are in North America, Europe, Western Europe, and Australia. Next slide, please. Next. I just want to finish this talk by saying that the cheapest way of HBV prevention is, of course, vaccination. And in that context, I just want to underline the importance of universal HBV vaccination. But the most important thing is that the first dose has to be delivered in the first 24, in the first day of birth, if possible. If that's not possible, in the first 3 days of birth. But in countries like Sub-Saharan Africa, such as Gambia, it has been shown that more than 90% of the first dose is given much later, and that could be one reason why we can still observe escape HBs antigen positivity in children despite being vaccinated, because they were vaccinated too late. Since my time is up, I want to stop it here. But before, I just want to mention that we are talking about HBV, and we should not forget about Delta hepatitis, my dearest topic. Thank you very much.